Just a minute. Just let me make a host. Give me a few seconds. Somebody has raised the hand. I'm not.
Oh, I need to stop sharing my screen, right? Or can you?
No, that's.
Yeah, I think Dr. Divyesh.
Dr. Devesh, just a minute. Devesh Dadania.
Yeah.
He is Dr. Ravindran. So, Dr. Devesh is Dr. Rajendran?
No, sir. Dr. Rajendran is actually raising his hand. You can just see.
Okay. I got it. I know it. I was not able to see. Okay. Hello, Dr. Rajendran. You can share your screen, share your video, and unmute yourself, please. Hello, Dr. Rajendran. Please unmute yourself, Dr. Rajendran.
Oh,
Yeah.
Can you hear me now?
Yeah. We can hear you. Good evening. Very good evening.
Yeah, good evening. Good evening, everyone. Thank you for this wonderful opportunity to meet all of you. I met Satish when I was in Chennai last time, and it was a wonderful experience. He was doing Pato, it was great that Chennai is doing well when, I left Chennai 20 years ago, and it's totally different Chennai now. I'm glad. So I want to. This is like a 9-minute talk, so I'll try to focus on a small area of prostate artery embolization.
So let me introduce you because possibly many of the members don't.
Okay.
So Dr. Rajendra is an ABR certified radiologist and has done this intervention fellowship training from University of Jackson Memorial Hospital, Miami and Birmingham. He is section head of intervention radiology at Boston Medical Center, clinical assistant professor of radiology, Boston University School of Medicine. So it's a pleasure that you have joined us for this webinar. And he is going to discuss what we need to know and learn from the cases of PE. Dr. Rajendra, you can now share the screen and start your talk.
Okay, all right. Can you see my screen now? Can everyone confirm they can see the screen?
No, not till now. You have to.
Okay, and I will try again. Oh, that's a different screen. How do I make it work? Share screen. Okay. Let me see.
Yeah.
Can you see the screen now?
Yeah.
It's a long screen. Okay, give me 1 second. Let me see if I can make it look here. Again, a long screen. And
yeah.
Which screen are you seeing? Like the presenter view or the big view?
The big view.
Okay, you got it. Okay, all right. So let's get started. We have been working with a urologist for a long time. I've been saving them for a while because we do a lot of procedures for them, and that is how we created a trust, and that is how we were able to get more cases in our hospital. So this is like one of the first few cases where they come to you and say, hey, this is bleeding like hell, what do we do? That's how we start. This is one of the earliest case where you can actually see there is CT sections showing a lot of blood clot in the bladder, and with a Foley catheter in and a huge sized bladder. So that's how we started. So I'm just going to go through some of the case scenarios, and then we'll try to get to the main presentation. So 3 different varieties of cases that we deal with are mostly like hematuria cases, massive hematuria. That's actually one of the most common one that we get. The second one is acute urinary retention following bladder outlet obstruction. And in rare circumstances, we are not started getting so many cases of those with irritative symptoms, like with the urinary frequency at night, uncontrollable on medications. Those are the cases which are on the low side. So jumping straight to the topic, like when to consider PAE for BPH with LUTS. LUTS lower, which means it's lower urinary tract symptoms, which is a mix of both irritative and obstructive symptoms. It could be one of them or combination of few of them. So one is a failure of medical therapy, refractory urinary retention, recurrent UTI due to BPH, gross hematuria, renal insufficiency, secondary to bladder outlet obstruction. Generally, we don't do anything less than 18 with IPSS score, which is actually the symptom score for prostate. And the QL should be more than 4. So I can show you those slides if you want. Those are basically the scoring system we use to evaluate these patients with the prostate artery embolization. So what we learned, good candidates and the bad candidates. The good candidates are the one with a large prostate, which is actually good because the prostate is larger the prostate, easier it is for us to identify the anatomy, which really helped in the initial settings where the anatomy is a little more complex. I can show you some cases. Patients who are catheter dependent, where they have no other go, so those, but you have to be very careful in choosing the patients because a lot of these catheter dependent patients are atonic, so there's no point in doing any kind of intervention on these patients. So it is important to have the urodynamic studies and document that the bladder function is there. Gross hematuria is the next common easy candidates. Patients who want to preserve sexual function, as you might know, the TURP is associated with ejaculation. Some people don't like it. Patients who are not a candidate for surgery, and patients who refuse to have surgery, because of TURP, they just don't like surgery. The bad candidates are the ones with a very poor renal function, they are vasculopath, severe atherosclerotic disease, though that thing is changing. We got more comfortable with the anatomy, so we can handle even patients with atherosclerotic disease, provided the artery is open. Prior hypogastric artery embolization, there's no access to the inferior sacral artery. Poor detrusor function, that's very, very important because at the end of the day, you need the pump to work, even if the outlet is open. Smaller prostates and predominantly median lobe hypertrophy, they are they respond poorly to prostate embolization. Patients with bladder diverticulum, bladder neck stricture, it's very important too. Patient who wants immediate results. These results take some time. So if someone wants immediate result, they can't have this procedure. They can still have. All right, I'm going to skip through the evaluations: clinical, lab, imaging. We try not to do too much imaging on these patients, except the patients who are, just ultrasound, just to look for the bladder, residual volume, prostate volume. CT can be done in the initial setting just to find out the degree of atherosclerotic calcifications. Kind of helps you with the, helps you find out oh, sorry, sorry, it's gonna begin, screw it up. Can everyone hear me?
We can hear you.
Oh, okay. Sorry. Go on screen share. Where is my screen? Okay. Sorry, I'm just this is new technology for me. Can you see my slides?
Yes, we can.
Okay. All right. Okay. Yes. Let's jump on to the pre-procedure. All the medications should be stopped at least 2 weeks before the procedure, just to see if the patient is responding, and we have to restart. When I say pre-medications, usually alpha blocker or 5-alpha reductase inhibitors, and then the antibiotics we administer on the day of the procedure, and then I continue for 7 days after the procedure. The initial times I try to put in a Foley balloon. If the patient does not have one, then I try to put it in just to locate the prostate, but like, got comfortable. I don't need it anymore, but like, so that's something that helps in the initial times. Groin access, radial access, whatever is comfortable with, you can do and get a pelvic angiogram. Right, this is the important part. I just want to quickly show that, which is the most important thing, is familiarizing yourself with the anatomy. Extremely important in the pelvis, male pelvis especially, because the prostate arteries are not big as the urinary fibroid. You can actually see a urinary artery from a mile for in the fibroid cases, whereas prostate arteries are really, really small. So it's very, very important to familiarize yourself with the anatomy. Oblique views are better than AP views to find out the branches. So they see the anterior and posterior division. The posterior division is easy because it has 3 branches, like the iliolumbar marked as IL, which is actually the first branch. The second branch is usually the laterosacral, and the artery that goes along the sciatic notch is the superior gluteal artery. And the anterior division is here. Let's see if this is the anterior division. And then like 3 important branches to remember, like, one is the obturator, usually like a fork kind of a thing. The second artery is the internal pudendal artery, like, the one that turns like an acute angle. And the one that goes down is actually straight, is the inferior gluteal artery. So this is like, common. This is done on a younger patient with erectile dysfunction. So no, the prostate arteries are not necessarily visualized. Different patient, trauma case where you obviously see the bladder is like, compressed, and oblique view. The inferior gluteal artery is the one that goes all the way down. The one that takes a right angle is the internal pudendal artery. And the one that wavy artery here you see is actually the obturator artery. So this is one of the common artery we embolize during, like, patient has a pubic rami fracture, like, that obturator artery is most often be the target. So AP view, a little more challenging than the oblique views. You can see this internal iliac artery. The one that swells and goes along the sciatic notch is the superior gluteal artery. One that turns medially this way is actually the inferior gluteal artery. Now the challenge is trying to figure out, this is the artery that you can see here. This is the obturator branch. And this is a branch that comes and takes a turn here. That's the internal pudendal. Okay. All right, so now how to identify the inferior vesical artery? The prostate artery arises from the inferior vesical artery. There's a superior vesical artery, which is actually the first branch, and the inferior vesical artery, like, sometimes they come as a common trunk. Sometimes they are separate, like, the superior vesical artery, the one supplies the rest of the bladder. The inferior vesical artery supplies mostly the prostate and the base of the bladder. Like, so how do we find out? So this is a view which actually consistently works. Ipsilateral 30-degree angulation. If you're doing the left side, so left side LAO 30 degrees and the caudal 10 degrees, which actually separates all the vessels to leave the prostate artery in place. Usually the Foley inflated with a little of contrast kind of keeps the position, like, tell us where to expect the prostate. And then you find out the location of the prostate and then try to trace the artery backwards. So in this particular case, you can see where the pointer is pointing, like you can see these 2 branches. So these are the prostatic branches here, and you can trace it back to a little wavy appearance of this inferior vesical artery. The artery that you see here is actually the superior vesical artery. The rest of the arteries are easy to find. Like, like this is like obturator branch. The pudendal is not filling it. Inferior gluteal. So once you're familiar with the anatomy, it's kind of, the procedure is fast, like, it goes on pretty quickly. The different anatomy, similar prostate, this one, internal iliac artery, and this is the iliolumbar branch, and you can see the superior gluteal artery here, inferior gluteal artery goes down. This is the pudendal artery, and this one you can see here, the one that bifurcates like this one is the obturator branch. So where to look for the prostatic branch, prostate artery action. In this particular case was done without a Foley bulb, like, as you might see. This is the expected location of the prostate in this area. Like, you just try it back, like, trace it back. You can see this wavy artery that goes on this one. This is the inferior vesical artery. The artery that goes in this side is actually the superior vesical artery. One more point I want to emphasize is that you don't necessarily always have near the origin of the anterior branch of the internal iliac artery. So sometimes the prostate branch comes from obturator and sometimes from pudendal. I'll try to show you some examples. Like, so it's important because I can tell you the reason why it's important. So this is a different anatomy. As you might see, very tortuous at the sclerotic aorta. So, and then the branches are like, all over. The one that takes a right angle and goes and like, this way is actually the pudendal. The one that goes downwards is the inferior gluteal. So you can see this little wavy stuff here. This is actually the prostatic artery. The artery, the obturator in this particular case comes off the superior gluteal. Actually, you can see it's coming off here and bifurcating into two different branches here. All right, this is selective cannulation of the prostate. Like, as you might see, you should also, it's also important to understand the anatomy within the prostate. That actually, like, shows you how the results are going to be. As you can see, there's a superior branch, and there's another branch that goes all the way to the periurethral area, and there's a branch that goes inferiorly, right? So collectively, the artery that's like, caudal and the periurethral glands are like, it's a prostatovesicular branch. It's actually, it's also called to the artery of the adenomas, like, which is actually the feeding the adenomatous hypertrophy, which is causing the problem for BPH. So it's important we should do the embolization to capture this particular area of prostate. This particular branch, actually, it doesn't matter if we embolize or not, because this supplies only the peripheral zone, not the central zone. So we use microcatheters, and of course, like, I try to use a smaller particles, like, so there's 300 to 500 mic, and then there's a study from Brazil, like, they showed that, like, the proximal embolization followed by catheter advancement into the periurethral gland and then distal embolization actually have a better result than just embolization proximally. The reason being, actually, so you take care of all these adenomatous tissue here, and then go deeper here with a microcatheter, and then inject a small particle, like, like 100 to 300 micron, to take care of the periurethral gland. All the symptoms are from this periurethral glands. Like, that's where you get the best results. Of course, beware of non-target embolization. The areas that you should be concerned is, like, when, let me see if I have an example. I'll come back. Okay, this particular case, as you might see, the catheter is taking a right angle, right? So this is the internal pudendal branch, like, so you can see this is the gluteal inferior gluteal artery. So it's very important that internal pudendal is important for two reasons. One is that the middle rectal branch comes off the internal pudendal. The second is that a non-target embolization, so if it happens, it end up with ulceration of the penis tip. So we, like, especially the dorsal penile artery getting like a little embolic agent, which is not good. So very, very careful about non-target embolization. I mean, this is more forgiving than other areas, like, so, but you should be careful. As you might see, this is a tiny branch that's coming off of the internal pudendal artery, and little delayed phase here. And this is selective cannulation, and this is post-embolization. Actually, you can see the blush has kind of disappeared. I'm just going to go back to where it was. Okay. All right, so this is the other side. Now, you can actually mentally picture and see how to identify the artery. Actually, so internal iliac, posterior division, anterior division. You can see the one that goes down is the inferior gluteal. One that comes and takes a right angle is pudendal. the one that bifurcates into a fork kind of a thing. This is actually the obturator. So you can see this particular artery is actually the prostatic branches. You trace it back. Actually, it's coming off of the obturator. So this is a different anatomy. Selective cannulation, and this is an ultrasound of a patient we obtained like 4 weeks, before and 4 weeks after the embolization. As you might see, there is a significant response. Actually, not just this patient, every patient we did the embolization, the volume actually goes down, with time. By the time they are 2-3 months in, they are like more than half of the prostate volume disappeared. All right. So just to reinforce the anatomy here, this is a prostatic artery. This is the branch, these two branches are called the prostatovesicular branch, and this is like the caudal branch, which supplies the peripheral zone. AP view, similar anatomy. I'm just gonna run through it. Very similar. This is another anatomic variation that you should be aware, as you might see in this particular picture. See, this is single trunk. That's common trunk for the superior vesicle branch. You see here that the one that goes superior vesicle. The branch that goes down is actually the inferior vesicle branch. Prostatovesicular peripheral zone branch. Post-embolization angio, you might see here, there is a branch that comes off here and goes towards the midline, and there's another branch that makes a similar angle. This is the internal pudendal artery, and this is the accessory pudendal artery. It's very common to have this variation. As you might see, the origin of the artery was very, very close. Any kind of embolic non-target embolization can go into this accessory pudendal artery. We talked about this. Post-care, usually we discharge patient after 4 to 6 hours, giving them some pain medications. Usually they have spasm. The pain, the pain is not as severe as the fibroid embolization, so we send them home. If the Foley is inserted just for this procedure, we remove it before the patient goes home. If it is done for acute urinary retention or even urinary retention, we usually remove it within a week's time. The patients usually respond well to NSAIDs, and antibiotics are given for a week. Be aware of the
Dr. Raj, you have 1 more minute.
Yes, I'm almost done. Aware of all these minor events, minor and major. Most of the times the complications are minor. The clinical success, by definition, is improvement of IPSS and QOL score, usually measured 3 months and 12 months interval. Technical success rate is 98% reported in the literature, and the clinical success rate is about 30%. There's a lot to go through about the evidence, but collectively, the PAE is, it's non-inferior to the TURP in many of the studies, randomized control trials. The complications are somewhat lower with the PAEs and somewhat higher score with the IPSS and QOL when compared to the PAE. The TURPS enjoys a little bit more, but in terms of preservation of sexual function, the TUPAE is much better. All right, I'm gonna skip. All right, so conclusion: candidate selection is important for PAE. Not everybody is a candidate for PAEs. Familiarize with male and pelvic anatomy, which is actually the rate-limiting step in many circumstances. Beware of adverse events. And PAE, based on the literature, PAE is non-inferior to TURP in many randomized controlled trials. The evidence is building. At some point, it will be accepted by the American Urology Society. Thank you.
Thank you, Dr. Ranjan. So we'll start with the next topic. This will be by Dr. MC Uthappa, who is going to present his initial experience of PAE. Dr. MC Uthappa, everybody knows, but still, he is head of intervention radiology services at Global Group of Hospitals. He is alumni of Mysore Medical College, and he did his training of intervention radiology and intervention oncology from the UK. So, Dr. Uthappa, share your screen and show us your experience about PAE.
Thank you, Arun, for the kind introduction, and good evening to all the people who signed up and taking the time out. And thank you to the Miracle team for giving me opportunity to share whatever little I have learned with my initial experience. Can I request Raj to come off, take your screen off, then I can get my screen
Give me
on.
1 second. Edit, hide self-view. Is that how it is? Oh, okay. Stop screenshot. Okay, got it. Got it.
Thank you. Are you able to see my screen?
Not yet.
Oh. 1 minute. How about now?
No.
No, not yet.
Oops. Sorry. Now?
can see your screen, but we can't see your PowerPoint.
Oh. Not yet? I thought...
So we can see your Zoom, your...
1 minute.
I think internet... your Explorer we can see, not
Yeah.
your PowerPoint.
Sorry, guys. 1 minute.
Can you stop sharing and then retry and choose PowerPoint this time? I think you have chosen Safari by mistake.
Nobody, I didn't. Wait, I'll say...
Minimize this and then try it.
Now?
Yeah.
Okay, sorry. Okay, so I know it's a real tight fit. And when Deepa called me, she said, can you sell some tips and tricks? And then I said, I've done so many cases. And then she said, okay, we'll change it to an Indian experience. So here we go. So I did the first case in 2016, actually. And that was an 84-year-old gentleman whose main problem was nocturia. He was getting up 4 times a night. And then through my own website, he reached out to me. His son was the Reverend Father. And then by then I had attended many international conferences and read about it. And I thought, yeah, this is for 2016, I must start a new procedure. And that's how I sort of got interested, did my background work and read about it and figured it out what to do. And then I did that. And after 1 year of follow-up, I actually did a newspaper publication to make enough noise in the community that we as interventional radiologists can have a treatment option for this. So that was my initial thing. So then obviously, so moved on from there. And now I'm going to just show you whatever I've sort of learned. Okay, so what I'm going to focus on is, 1 minute, I need to get rid of this. Yeah, so what I'm going to focus on is patient selection. One of the important areas is workup CT angiography of the pelvis, some pre-procedure, procedure, and post-procedure issues. And one important point for beginners is that it's not in UFE. One would like to say that before you do your first PA, you should have done enough UFE, but that's not quite enough because clearly you will know once you've heard many talks that it's not a UFE. So that's an important point. So in patient selection, I think what is important is that we have to have a consultation time of at least 30 to 45 minutes because there's a lot of history to go through. You have to get used to doing a scoring and then also a screening ultrasound, which has to be done personally by yourself. I won't go into details of this because there's a lot of overlap between LUTS, BPH, and BOO, that is blood outflow obstruction, and a lot of the symptoms can overlap. So it's important to go through the history and be absolutely sure that you're dealing with BPH related symptoms. So the IPSS scoring is available on the internet. You can go through the symptoms, as you can see, from 1 to 7. And then based on the severity, the patient has to score. You can help them do it in big centers. They have a nurse practitioner doing it. But when you are starting off yourself, I think you should personally sit and do it, put a score on, print a sheet if you don't, and then document it. So what you're really looking for, at least the patients will come to you, is probably in the severe category. 20 to 20, 30, 35 will be the score. And there's also a quality of life score, which is important. At least when you start your first initial cases, it's important to have this, because then when you do your follow-up, you can see that you're really making a difference or not. So it's very important that in your consultation that this has to be done. So one important point about ultrasound is that I think it's important that as part of your consultation, one should do your own ultrasound. One is to really look at the morphology. One to do the size measurement, because even though you may have a report from outside, it's important that you do your own ultrasound measurement, get a real three-dimensional measurement, and then also do the pre and post-void residue. It just gives you a confidence that you're dealing with whatever symptom correlation with your own ultrasound. And as we know in our practice in India, it's important that you do your own ultrasound and not rely on outside report alone. Euroflowmetry, there's a lot written. I just wanted to show you that you have a normal curve which is seen on the screen. And then what you're really looking for is the curve number 2, as you can see here. That is what a BPH curve looks like. And number 3 is ureteral stricture. So it's important to just get a little bit familiar about what a uroflowmetry looks like, so that you know when you have a graph like this and your symptoms are correlating with your IPSS scoring, that you're dealing with a patient that will probably benefit from your procedure. Now, starting off, it's extremely important. There's a lot of beautiful publication and different presentation, as Raj has already shown you. It's important that we spend a lot of time on the CT. So my way of assessment is I have to do a CT angiogram of the pelvis to be able to, one is to select the patient's curve perfectly, one is to map the anatomy, and also to be able to then counsel the patient and then also help you in planning the kit. And believe me or not, it will take you at least 30 minutes initially to be able to see these prostatic arteries. So it's getting familiarity with the anatomy. It will also be able to tell you on the day of your procedure that what obliques will be able to identify which artery. So spend a lot of time, like we do for a pre-TACE procedure for our hepatic arteries. You'll have to spend double the time in the pelvic anatomy to understand the prostatic arteries. And it's important that you supervise the CT angiogram. A simple protocol to remember will be 100 ml of contrast at 3.5 to 4 ml per second, and then also to be able to give vasodilator on table. So we normally use nitroglycerin, 50 micrograms, provided the ECG and other parameters okay. But in what the take-home message is, supervise the CT angiogram yourself so that you can get brilliant images and review of the anatomy. So yeah, this is something, a typical image which I put, and you can see that as I'm playing that, you will be able to see that the density of the prostatic artery just going through on the screen is very well seen. And I can just pause that. And you can see here the left and the right prostatic arteries are seen very well. So when you see an anatomy like this, that it will be fairly easy for you to be able to identify. So it's very important that we focus on getting good CT angiogram. Now, pre-procedure, obviously it can be done as a daycare procedure. Consenting is obviously like any other procedure is important. Antibiotics, what you want to give, that you can follow your local protocol. Normally we give an intravenous dose on the day of the treatment and then continue oral antibiotics for 7 days after the procedure. And if you have a patient who's got a catheter, then obviously that has to be discussed. If the patient got hematuria, that has to be taken into consideration, and then what you're going to plan after removing. So it's important that you take these points into consideration. Now, anatomy, I can't stress anymore that anatomy is the super key importance of these procedures. A lot of the IRs will be experienced in doing embolization, but prostate artery embolization is slightly different kettle of fish. This article from Bilhem is one of the initial publications, and I would encourage you to please read this paper, and it will tell you. So the commonest anatomy has already been covered by Raj. I just have to tell you that it is never enough time that you have to spend a lot of time. So the commonest ones are the internal pudendal artery branching and the superior vesical artery that the branches will come out from the prostatic arteries. And then, like I said, it can come from obturator, your accessory pudendal, which will be parallel to that, then some rectal branches, very rarely superior gluteal, common trunk, and also inferior gluteal. So Raj showed you some cases. You should be wary that any of these can give you a prostatic artery. And in each patient, I mean, I have had a patient once where we have done from 3 branches from 3 different areas in a short experience. So I have only done 14 cases so far, and I've already seen a huge amount of variation. So that is something to watch out for. So on the day of the procedure, I thought I'll highlight a few points that it's very important that you block your cath lab for 2 to 3 hours. You know, when you start off initially, it won't be like our fibroid embolization, 30 minutes in and out. It will probably be 1 hour on a very good day. If you have a very good CT angiogram and you've seen the anatomy very clearly and you have a learning curve that you've crossed, it can be done purely under local, but a lot of these patients are elderly and they have to lie down for 2 to 3 hours. It's important, I think, to have IV sedation on board so that they don't move unnecessarily during your important image acquisition. We have now exclusively moved to radial access, but if you're not comfortable yet, you can also do it in femoral. Very important to make sure that all the kit is available. Anatomy and imaging is the super important key. Vasodilators, you should be fairly generously used, and it is sometimes useful before the angiogram and before embolization. I tend to say to my team that keep Visipake ready because the contrast requirement is quite high. These are elderly patients, they may have renal issues. So it's important, I tend to use Visipake. And embolization technique, I can't say any less than apart from meticulous technique, you will not get the good results. Sorry, I won't go into this. This is just the hardware to show what we keep ready for a radial access. You know, the standard thing, we won't cover this today. And then, so a simple way to do it is radial access. You have I tend to use a vertebral catheter. You can have a hydrophilic one if you can get hold of that 125 centimeter 4 French access kit, and then 4 French vertebral catheter. So I place that into my internal anterior division of the internal iliac artery and then start doing your mapping and angiogram. Of course, microcatheter I have used, my favorite has always been a Progray. For other embolizations, I tried them in my PAE initially. Some I got away with, but then very soon I realized that you have to use a 1.6 or a 1.7 French microcatheter. It is up to you what you're comfortable with. I've just listed some which I have tried from Terumo, from EV3. They all have their advantages. I tend to use a Whisper 014 wire. I can shape it well, and I want to get in as distal as possible with this. Many times the 1.6 French by itself, you can get into the proximal part of the PA, prostate artery, but to go distal, you'll obviously have to have a wire to help you with that. And then we tend to use 100 to 200 micron PVA particles. Very more recently in India, we have Progray Alpha available, and I would encourage that would be a very beautiful catheter you use in the. Now, one important point for practitioners from India that in PAE, I don't think there is any role for Oxford material. It has to be everything new. You could probably get away with a uterine fibroid embolization with an old microcatheter, but certainly not PAE. It has to be everything new catheters. Therefore, your costing has to depend on that. Just to show how we set up the room, just, you know, it's very simple, nothing fancy required. Radial access, we position, this is our usual position, just to show if you're starting off how to position your room. So I probably won't have enough time to cover the anatomy, but just to say that once you've done your CT angiogram, you can see the left side prostatic artery very clearly. A lot of DSA is probably required in this procedure, unlike uterine fibroid embolization. So obviously you have to use it, but generally you get very good DSA in the pelvis. There's hardly any movement, so you should not have a problem with identifying these vessels. So obviously roadmap, general use of roadmap is very important. So you use your roadmap, you're able to go with one contrast opacification from your proximal catheter, then you take your microcatheter in. Obviously, like Raj has shown you, you go as distal as you can and outline the opacification. I don't use a urinary catheter in any of our patients. we tend to manage without it. You can see the impression, obviously contrast. It's taken so long for us to get to this point, you can see, and then once you are identified your position, then you can go ahead with your embolization. Sorry, I'm just going to show you the end point, how we can look at the end point on your right hand side of the screen, and then just to show you the non-DSA and the DSA image at the end point. Similarly, we go into the right side. This was much more challenging. We could see the prostatic artery. It's this one here, just coming out. Obviously, you need multiple obliques to be able to get to it. It'll take a lot of time. Sorry, excuse me. It'll take a lot of time. So we can get into it. Spasm is very common. Don't be surprised by it. That's why I told you, before you cannulate the prostatic arteries, you must put nitroglycerin, 25 micrograms. Sometimes even before you do your, and then before you embolize, you can get into it. So you can see your left-hand side of your screen. You can see the prostatic artery position with the microcatheter and enhancement. And this just to show you a static image outlining all the branches of the prostate. This was the first case which I did in Bangalore, just to show you that this was a unilateral attempt, because the right prostatic artery in an 84-year-old was very calcified and extremely small. And we were able to give him a clinically beautiful result, even with one-sided embolization. This is the pre and post procedure. This is way back in 2016. Another example, the top end, you can see your pre-imaging, and then you can see post-imaging. You always get a little bit of venous filling, and that's something we also see after fibroid embolization, almost the end point time that you see when your embolization is complete. Just to show you some more examples, pre and post images, DSA images, to be absolutely comfortable that you blocked all the branches of the prostate. So when we started doing initial, we sent in our initial experience to JCIR. Unfortunately, it was not accepted, and then we keen to send it to Polish Journal of Radiology. And why I wanted to share this with you was just to say that when you do your initial few cases, you have to do all this quality of life, IPS scoring and volume, and do it at your own personal study. And then you can see that we could get clinical improvement in up to 10 points. We got improvement quality of life of 4 points, and the prostate volume reduction in a short-term follow-up of 22%. Even what is interesting is, even if you get a 15 to 20% volume reduction, you'll get a significant symptomatic benefit. What you have to imagine is the central part of the gland is actually causing the obstructive symptoms. You're able to embolize that, and that will give you a good result, and also improvement post-void residue. We can see 54 ml to 30 ml. I think it's the important is this IPS scoring and quality of life that what really matters for these patients. Post-procedure, just a points to remember is probably 48 hours of painkillers for most of the patients. We give antibiotics for a week. Like I told you, we normally use Ceftum 500 mg BD. I see them in the clinic at 1 week, and if their patient does come with hematuria or previous catheter, I do a trial without catheter at 2 weeks. YPAE, I think we'll hear more and more. I think it's all there in the, it's fairly straightforward. And just to thank my team for, always, these were the first 2 fellows. These are the second fellows, and our current fellows are Kalai and Fahad. And Rohit, who has helped me significantly in not only doing the cases with me, and also helping me with prepare the presentation. So thank you. I have to peel away. So if there's any questions specifically for me, I prefer if I can take it now. I don't know how much time we have, Arun. Thank you very much. So
thank you, Tapa. And I would say the best part of your talk was the images, the cath lab and your suite images. You have seen that you are standing behind and your fellows are working in the lab.
Sure.
So let me see if there are any specific question for you. So I think we'll finish it first, then we'll say because I think if there are any questions, any other can answer it. So we'll again, we are talking about the residents. So we have a fellowship student of IR also, Dr. Irana, and I would like him to tell us what he thinks about the basics of the PAE and his experience.
Hello, sir. Let me just share my screen.
Dr. Irana is at Rayla Institute and Medical Center. He's doing first year intervention radiology fellowship.
Is everyone able to see my screen?
No, not now.
Not yet, sir. Are you seeing it now?
Yeah, make it full screen.
Is it okay now?
Yes.
Okay, sir. Thank you. Today I'll be speaking on prostate artery embolization, the basics. I'll be covering more of clinical perspectives. Let's see. All the indications and most of the speakers have already covered. So I'll start with pre-procedural evaluation. Start with the clinical and lab evaluation. Our clinical evaluation should include IPSS scores, and it's important to have the erectile dysfunction scores also. That is the SHIM scores. And you ask the patient what medications he is taking currently and what anticoagulants he is taking, which helps in planning. And then you also need to rule out the coagulations. This is just a simple algorithm how you have to start approaching the patient clinically. A 40+ male with bothersome LUTS will come to you. Just see if he has got just polyuria or is it nocturnal polyuria. Polyuria is more than 3 liters per day. If he has got just polyuria, then just advise him lifestyle modification and reduce the fluid intake. If he has got nocturnal polyuria, that is more than 33% of the volume is at the night, then you have to advise him to reduce his fluid intake and also consider other causes like the bladder outlet obstruction, neuromuscular dysfunctions, all these things you have to consider. And if it is just nocturia, what you have to do is you have to treat with the standard treatment, that is the restrict the fluid and diet, and then give him the standard medical management, that is the alpha reductase, 5-alpha reductase inhibitors and alpha blockers. If he fails this treatment for 3 months, then you have to evaluate further and consider him for PAE. A detailed evaluation should include the uroflowmetry and urodynamic studies, which I'll talk in the next slides. If you are sure on urodynamic studies that it is bladder outlet obstruction, try the medication for 3 months and then offer him PAE if this fails. If you are not sure that it is just bladder outlet obstruction and it is mixed with overactive bladder, add antimuscarinics to the medical therapies and try and see if it works. If it fails for 3 months, then go ahead and offer PAE to him. Once again, if it is pure overactive bladder, what you have to do is just give him behavioral therapy and add an antimuscarinic and see. If it doesn't work, you have to consider invasive therapies for overactive bladder like Botox injection or a neuromodulation. So what are the lab tests? The lab tests should include the routine CBC, RFT and coagulation profile, and then you have to do urine analysis to rule out the infection, do the uroflowmetry and urodynamic studies, and then have a PSA baseline which helps in ruling out prostate cancer. The uroflowmetry and the urodynamic studies, this is a very good paper in JVIR, you have to, which is specifically written for interventional radiologists. So let's see what is uroflowmetry. In a uroflowmetry, you ask the patient to void his void in such a small cup, and a computer will generate a map like this. At this point is the Qmax or the maximum flow rate, and if the Qmax is less than 10, offer him PAE, and if it is 10 to 15, it's an unequivocal test. You have to ask him to do further urodynamic testing. If it is more than 15, it is not bladder outlet obstruction. You have to consider possibility of other causes. This is a normal bell-shaped curve you can see, and this is one of the examples of a uroflowmeter with a Qmax less than 10, and you can see a small flow. This is another example where you can see there are multiple crests and subs, which is actually correlating with the intermittent stream of the urine. Urodynamic studies are mainly of 3 components. One is the cystometry or the filling phase. Next is the pressure flow study, which is taken during the voiding phase, and another is a EMG probe, which will tell us about the urinary sphincter. For a urodynamic study, you place 2 manometer balloons, one in the rectum and one in the bladder. Then you infuse 1000 ml of warm saline into the bladder, And then all the while you measure the pressures in the bladder and the rectum. And finally, you ask the patient to void and you measure the pressures as well as flow rates. So this is a sample cystogram. You can see those are the pressures which are measured. One is the vesical pressure, the other one is the abdominal pressure. Using these two, the detrusor pressure is calculated. And then on the fourth line, you can see the neuromuscular activity. This electrode is attached to the external genitalia or the skin, where you can see the neuromuscular activity. Here you should be very careful that this neuromuscular activity has to correlate with the detrusor, highest detrusor pressure. Otherwise, it might be a neurogenic bladder and you have to rule out that. This is in the voiding phase. You can see in the first part of his voiding phase, he's having a high detrusor pressure. That means the bladder is contracting well. But even then there is a slow flow, that Qmax is low. That means only the bladder is obstructed. There is no other problem with the contraction of the detrusor muscle or the neuromuscular activity. Using these values, you measure, you plot these values on something called as nomograms. One is the International Continence Society nomogram. The other one is Schaffer nomogram. Any plotting that you get in this blue zone or in the red zone, you have to offer them PAE. This is another bladder outlet obstruction index, which is calculated. If it is more than 40, you call it obstruction. Otherwise, it's an unobstructed. Having a baseline PSA is very helpful. This is an age-wise normal PSA trend. Anyone in his 40s should have a maximum of 2.5 nanogram per ml. And for every decade, it goes on increasing by 1 nanogram per ml. This is important because when you have a baseline and you perform a PAE, immediately post PAE, there will be 20 times increase in the, up to 20 times increase in the PSA. But after the procedure, within 1 month, it will come back to half the baseline value. Then we'll see imaging evaluation. First is you will get first you have to do the truss or transabdominal ultrasound and measure these values, size, symmetry, and PVR. If there are any suspicious nodule, go ahead and perform an MRI. And on MRI, you have to see how much of prostate is protruding into the bladder. That is intravesical protrusion of the prostate, or the thickness to height ratio, and give a Pyrad score so that it will help in further management. If on doing these two, you decide that the patient has to get a PAE, then go for a pre-procedural CECT or a CEMRA, which is under development, which helps in guiding the prostatic origin and to look for any dangerous anastomosis. And finally, you do use the DSA and CVCT together, which helps in better outcomes of your procedure. One note on the transabdominal and transrectal ultrasound. In the normal and early stages of prostatic growth, that is up to 55 cc, you can see the prostate looks somewhat like a bullet shape. But when you see more than 55 cc, it is more like an ellipsoid shape. So for the formula that we use to calculate volume for ellipsoid holds good for advanced stages, but for early stages, it is better to use this bullet formula where the multiplication factor is 0.65 rather than the 0.52. On MRI, you see the symmetry, measure the thickness to height ratio, and Pyrads. This is one good paper where they studied on 82 patients, and you can see they measured the thickness to height ratio. They selected a sagittal section where the prostatic urethra is seen, and they outlined the bladder base. Then they measured the thickness of one of these lobes, and then the height of this. Similarly, you can measure it on the coronal also. So the importance of this study was that this IPP index, or the thickness to height index, if it is less than 1.3, they found out that the complications were much higher when you perform PAE. Further use of CECT, simple CECT protocol. Inject the contrast at 4 to 5 cc rate. Place your ROA in the abdominal aorta. Use 2 to 3 mm thin sections, and then use 3D MIP, which will help in prostatic origin identification and the angiographic anatomy. And don't forget to use the sublingual vasodilators, which are helpful in identifying the small prostate arteries. So this is the Carnivale angiographic classification, which everyone has nicely described. Usually CECT will be helpful in type 5, that is the origins which are apart from these 4 common origins. This is one such example where the superior gluteal origin of prostatic artery is seen. Without the help of CCT, if you took just the anterior trunk DSA in this, you could have missed this prostatic artery origin. This is a aunt meaning. Usually, this is a case of corona mortis. You can see this is the external iliac artery, and this is the inferior epigastric artery. From this, there is an accessory obturator artery which is coming, which is giving rise to prostatic artery. So such cases, the CECT will be more helpful, and using the DSA as well as CVCT during procedure. So when you do a hypergastric run, identify what is the branching pattern, and usually the first branch which courses medially, which is very small and not so easily identified, is the umbilical artery. And the most common pattern of branching will have the superior gluteal artery in the posterior aspect, and the anterior trunk will give rise to pudendal artery and the inferior gluteal artery. So use the Provisio algorithm, which most of them have told, and using the 20 to 50 degree ipsilateral oblique and caudal orientation is very important. If you're starting the practice, always use the contrast filled Foley's bulb to identify the prostatic artery. You can see first branch is the umbilical artery. Next branch is the superior vesicle. Third branch is the inferior vesicle. Then this fork-shaped or inverted V-shaped ending is the obturator artery, and the terminal branch is the pudendal artery. Some of the CBCT protocols, Dr. Satish sir has already explained in detail about the CBCT. Always when you're doing a CBCT protocol, give GTN, which will avoid dissection and increase your yield of the procedure. If you are planning to use a power injector, set the pressure flow rate to 0.3 ml per second and use a total of 5.4 ml of contrast and 8-second delay. If you're using hand injections, use 3 to 5 cc. Make sure you use diluted contrast, and you have to start injecting 2 seconds before you start rotating the C-arm. And once you start rotating the C-arm, set it to 6 second speed. This is specific for the prostatic artery. And take care that you do a very slow injection, otherwise you will end up damaging the prostatic artery, which is very small. Some tips to reduce the artifacts: use dilute contrast, low to voltage, and then use some special metal artifact reduction filters like the CMR filter on Siemens machines. This is one such instance, one classification which is not so explained in all the presentations. See, this is very important when you do a CBCT. This is a compartmental blood supply of the prostatic artery. There are 3 types which are described. First type is a single compartment with a single pedicle supplying. And the second part is the single compartment, but 2 pedicles supplying the artery, prostatic gland. And in the third type, there are multiple compartments which are supplied by multiple arteries. So I'll just tell you, this is one of the type B arteries which was seen on cone beam CT. Here you can see there are 2 separate origins of the prostatic artery. If you have seen, normally they have explained it as a single origin and then supplying each of this. The importance of this will be, you can see in this paper, they studied 10 patients which were repeat prostatic artery embolizations. In their angiograms runs, they felt that the posterolateral capsular branch was the most common artery which recanalized the prostatic arteries. So this will help in, this shows the importance of embolizing the posterolateral branch, and CBCT, which helps in dividing, helps in that. This is the type 2 pattern which I explained. There are 2 issues with type 2. One is the non-target reflux, and the other one is the competitive inflow. Non-target reflux can be avoided by coiling this branch, and the competitive inflow can be avoided by separately embolizing each of the branch. Otherwise, the patient will end up having a recurrence. With the type 3 pattern, there are multiple compartments which you will not see only if you take a DSA run. Usually, what you have to do is, when you see a DSA run, you have to see for the prostatic artery, this one, prostatic parenchymal blush. If you feel that if it is not complete, you should go for a CBCT, and then you can see there is only enhancement in only one part of it and not on the other part. So you have to go and canalize the other branch and then see for the enhancement, and you have to embolize each of these branches. One note about the dangerous anastomosis: anything that runs below the superior pubic ramus straight down is a dangerous anastomosis, and you have to be very careful while embolizing the prostatic artery. And anything that runs vertically downwards is again dangerous anastomosis. See, you will end up having penile necrosis, or you can end up having rectal ulcers if you don't identify these things. How do usually these are self-limiting, but you have to be careful. But there is one thing which you can do to avoid this. That is by using a microcatheter with balloon. When there is no balloon inflation, you can see that there is a forward flow into the anastomosis. But when you inflate the balloon, you can see there is a competitive influx or a negative reflux, and there is no. So when you are injecting embolic materials, those won't go into the anastomotic sites. This is one of the sniper balloons, which comes in straight tip and K tip, or a 45-degree angle tip, which is most commonly used in balloon occlusion prostatic artery embolization, or they call it BDO. See, these are two of the angiograms. This is one with the balloon deflation, and this is one with the balloon inflation. With the balloon deflation, you can see there is some amount of contrast which is refluxing, and the same does not happen if you have a balloon inflation. This is another such example. Here you can see with the balloon deflated, the prostate parenchyma has not completely opacified, but with the balloon inflation, it is opacifying completely, and that gives us an idea that you can inject more of embolics into this with the help of balloon inflation. This is another such example where you can see with the balloon deflation, you are seeing the anastomosis here. But with the balloon inflated, you are not seeing that anastomosis because of a negative pressure gradient. So you can give your embolics easily now.
Dr. Anna, you have 1 more minute.
Yes, sir. This is a crossover anastomosis where you can see a single artery which is crossing over to the right side also. So you can perform prostatic artery embolization from one side. If you already catheterized the left side, you can perform embolization from the left side itself for the right side also. This is one such study which showed positive results in that. Some of the recent advances, this is a 4D CT angio study. This is the protocol they used. Using this in 22 patients, they were able to identify 100% of the prostatic arteries, and then they characterize what are the perfusion values for these prostatic arteries. Again, contrast enhanced MRA is under the investigation. This study involved 100 patients where they used these three equations, and they were able to identify the prostatic artery for 91% of the time with 100% positive predictive value. And they randomized into two groups, 50 patients receiving the MR angiogram, 50% not receiving the MR angiogram. In the patients that received the MR angiogram, they found out that there was less fluoro time, their procedural time was lesser, and the radiation dose was also lesser. Some of the complications I'll just tell you. Post-embolization syndrome may not require any treatment, just reassurance and symptomatic management. The bladder symptoms, that is the urgency, spasm, and clots. Usually vesicare and pyridium should help. When you are suggesting pyridium, inform the patient that his urine can turn into orange, and there is ask the patient not to use contact lenses. And prostatic symptoms, retropubic pain, burning, and retention are because of the prostate. Usually they can be managed with toradol, Percocet, and sitz bath. If there is acute urinary retention, consider catheterizing the patient. The rectal symptoms, complications, spasms, proctitis, constipation, and bloody stool. Usually Dulcolax will help with the constipation, and the sitz bath can help with the proctitis. One point to note down is never scopy these patients. Scopy is not required unless you have acute emergency. And penile complications such as balanitis, referred pain, or sexual dysfunction. So these are usually self-limiting, and you can use a lidocaine or steroid cream for penile ulcers. Some other other complications such as UTI, inflammation, and hematospermia. Hematospermia is usually it is a self-limiting, and you can use anti-inflammatories and antibiotics for the management. So your post-procedure should involve treatment should involve anti-inflammatories, ibuprofen for 800 mg TID for 7 days, and then urgency and bladder spasm should be, you should give vesicare for 5 mg OD for 7 days, Ciplox 500 mg BD for 7 days, and then for constipation Dulcolax 20 mg for 7 days, pyridium 100 to 200 mg you can add for burning for 7 days TID. Thank you. That was my time. And these are some of my resources for PAE. You can all have a look at it. Thank you, sir.
Thank you, Dr. Rana. I think you just please stop sharing your screen. So we'll have just few discussions. So I think I'll start with Dr. Raj. I have a question, two questions for you.
Yes.
So Dr. Raj, you have said that the big prostate are good candidates.
Yes.
Of course, we know that the prostatic arteries will be big, easy to canalize, and possibly that. But if we see that bigger the prostate, don't we think that the chances of failure should be high when we are dealing with the big prostate? Or is there any data to suggest that yes, the big prostates overall response is better as compared to medium-sized prostates?
I don't know if the data is good enough to examine based on the size. What we have seen, like, there's a saying, right? So if you do like 15, 20 patients, or like, it's an experience, it's not an experiment. So based on our experience, what we have seen is most of these patients respond very well. The size of the prostate, even though the size of the prostate is huge, if you target the median lobe, like in the periurethral gland tissue, they do respond very, very well. So especially the ones with obstructive symptoms. What we have seen is that, like, patients with the predominant median lobe hypertrophy and coming with the hesitancy and, like, or like urinary urgency, those are the patients who will take little time to respond. They don't respond right away. It will take about 3 to 4 months before they see a good response. Like, so that's what we are seeing. As far as I know, there is no big difference between a large-sized prostate and a medium-sized prostate for this one. It's not, like, unlike the UFEs, when you say really large UFEs, like, don't tend to respond well to the embolizations. But on the contrary, yes, I've seen that the response seems to be equal.
Okay. And one more question: you have told that the medications which are ongoing that for this BPH problem, they have to be stopped 2 weeks before that.
Yes, usually.
Any rationale for that?
Basically, we want to see if this is, like, this is not randomized, like, tried, or, like, any studies done specific on this. The rationale is that you want the response to the embolization to be, like, perceived. Like, if the patient continues to be on medications, we don't know if the patient is continuing to have improvements because of the prostate embolization, or is because of the ongoing medication effect. And the whole idea of doing prostate embolization is that, like, so they can stop their medications.
Dr. Satish, I have a question for you. That when we do the PAE, when the symptoms starts improving, and adding to this question, at what time we should think that no, it has we have waited enough and this is not working?
Well, I guess it's down to the relationship between the patient, because some patients, as one of the contraindications of poor patients that Raj was saying, is patients who expect immediate results. But anyway, most of the literature quotes you have to wait at least 3 months. 3 to 6 months is about the time that you would say that, well, this has not worked. And there is a big difference between the objective finding of shrinkage of size and IPSS improvement, because there is also a theory that there is a element of prostatitis that improves with PAE. And that's why we are able to get patients off catheter within 15 days, 20 days of PAE, even though one may find that the size has not decreased greatly. So again, that is one problem we have with convincing the urologist, and same with fibroids as well, right? Because Many of them don't shrink too much in size, but the patient has improved phenomenally clinically. So I think it is to go with clinical improvement. And if we have counseled the patient beforehand and say that, look, we'll wait for 3 to 6 months before saying that this is not worked. And if the patient is willing to take that, then they would be ideal candidates.
That's right.
Sorry. I was mute. So Devesh has asked, do you use routinely CBCT in all test cases, Dr. Satish?
Yes, almost all cases. Very few cases we don't, but I would say in the excess of 90% of the cases, we will use CBCT.
Dr. Raj, there is a question for you. Which route is preferred, radial, bilateral femoral, or only one side of femoral artery, and why?
So so far I've been doing only femoral access, only because we are in the early stage. And second, more important problem is that we have tall dudes here, right? So they are really tall. So our 125 centimeter catheter may fall short sometimes, so it's sometimes really hard to judge who's going to, because it's you can say, okay, tall dude, but they may have a long hand, or short dude with a long hand, so. There are chances that we may fall short trying to reach the pelvic artery. So I try to do the groin access. It's always single femoral access, no double femoral access, because we're so much used to like doing the UFEs, so on a single access. So that's pretty much. But I do like for radial, we do for all of the interventions like TASE, even for UFE, we have done quite a bit of TASE, radial access, but like for prostate, I would be a little bit careful.
Okay.
Yep.
So is daycare embolization feasible?
I mean, that's what we do. So we always send the patient home, but they always can come back to the emergency department, and like very rarely they come back, because you have to counsel them ahead of time about the spasm, the pain that they have, and go with the scripts so that they can have the medications. Yeah, we do daycare. Even the fibroid embolizations, we send them home same day. Okay. Many times.
There's one more question. That do you mix the sizes, means first smaller particles, bigger particles, or how would
I mean, the size is being based on the literature, what we use is 300 to 500 is a standard size. If I'm doing a periurethral, I'm just going deep, and then I use a smaller particle to get a better ischemia.
Okay. So I think we discussed all the questions, whatever feasible. And I would say that Dr. Deepa Shri has also to present this topic on testicular vein embolization and pelvic embolization also, but we are, because of the time factor, we are not able to complete it. Possibly, Deepa, it's your responsibility, yet you have to take another webinar on both these topics next time. Okay, thank you all. Thank you,
Absolutely.
Dr. Rajendran.
I will do it.
Oh, thanks a lot. Thanks for having me.
Thank you very much.
So we'll see you soon.
Thank
Good
you
night.
so much.
Good night to all of you. Bye-bye.
See you. Good night. Bye-bye.
Good night.
Good night. Bye-bye. Thank you, sir.
Bye.
Thank you so much.
ठीक है सर, वो रिकॉर्ड मैंने कर दिया है।
अच्छा, मैंने भी कर दिया अपने।
हाँ ठीक है, यहाँ पे देखता हूँ कन्वर्ट नहीं हुआ तो आप वाला सेव रखना।
चलो ठीक है।